I'd like to talk about some structures and systems overview of the body. So to start with, we're going to start with bone. Bone has an outside hard surface called the cortical bone. It's the shell of all bones, and inside is the cancellous portion of the bone, which is very vascular in nature. It includes the nutrients, and together they help to support the body, the muscles, so we're not just a puddle on the ground. And the bones, due to their vascular nature, heal relatively quickly. So if you've ever had an injury or know friends that have had a fracture of the bone versus maybe a sprain or a strain of a ligament or tendon, think, how long does it take for a fracture to heal versus a hamstring tendonitis, for example? So bones typically will take 6 to 10 weeks to heal versus a tendonitis can take months, maybe even a year or longer to heal. And that's usually due to the blood supply. So even though you may have a fracture, it may seem like a long time when you're in a cast. 6 to 10 weeks actually goes by pretty quick compared to a tendon injury, which can take much, much longer. So moving on to cartilage. Cartilage is a lining on top of the bone. So there are long bones in the body, such as the thigh bone of the leg, the femur bone, or the shin bone, the tibia bone. And on the surface of the tibia and the femur, for example, and even the patella, the kneecap, there is a type of cartilage that lines the surface that helps with friction control and protects the bone. The thing about cartilage, though, it does not have good blood supply. And there's a little bit of controversy right now saying that cartilage is not able to repair itself. So for example, if you or yourself, a friend has had a knee arthroscopy, you can actually see the surface of the bone where there might be like little divots or holes. And that's usually the cartilage that's been worn away. So old school thinking is that the cartilage cannot repair itself due to the lack of blood supply. However, there is new technology out there now using stem cells and various other methods that are helping to heal some of the cartilage. So, keeping in mind that if you practice yoga aggressively or run frequently and you are wearing down your cartilage, that might be it. However, going forward in the future, there might be some opportunities where the cartilage will be supported so it can heal, but it is a little bit limited right now. So there's 3 types of cartilage. There's the hyaline cartilage, which is most common. It's also the weakest. And it's the cartilage that I was describing on the long bones of the tibia, the femur, the ribs. Then there's also fibrocartilage, which is the strongest type of cartilage. It's found in the joint capsules. It helps comprise joint capsules and also the discs of the spine. So a little bit more pliable or elastic or movable. However, if something goes awry with them, for example, if you have a disc herniation or a rupture, it takes a very long time to heal. And it may be a permanent thing, but not always. So just know that fibrocartilage is one of the strongest. It helps, for example, in the shoulder joint, a lot of stability for a joint that just inherently has a lot of mobility due to the shape of the bones. Meaning that the glenoid fossa, we'll get into this more in the shoulder joint, but just a sneak preview, the glenoid fossa has a little bit more of a shallower cup where the head of the humerus sits in. So the joint, and due to the just nature of most of the stability of the joint is from muscular action, the joint really helps with, the joint capsule helps with a lot of stability. So elastic cartilage is found in the ear, the nose. It's, again, much more flexible. And if you've ever injured those areas for the nose, depending on the degree of severity, for example, may or may not heal. So moving to the next structure, most of you are probably familiar with, just due to your own personal experience, the muscles. And if you look at most anatomy books, they actually picture muscles in red just due to their high vascular nature, meaning that they receive a lot of blood flow. So if there's a muscle strain right in the belly of a muscle, it usually will heal relatively quickly, again, depending on the severity, but a minor strain will heal in the time span of a few weeks because it's getting good blood supply. So muscles have the ability to expand and contract due to the physiology of a muscle. You can get very detailed into this with sarcomeres and Z-lines coming together and apart. As we build strength, the amount of sarcomeres that we have increase, and muscles are broken down into groups of fibers, which then are also broken down into smaller components. So it can get very detailed. This is just a very basic overview. They help to provide stability for the body in an active sense, so meaning consciously you use the muscles. Sometimes muscles are used unconsciously, like the postural stabilization muscles. They are helpful with shock absorption, and then of course just getting us around. Tendons connect muscle to bone. So if you look at most anatomy textbooks, for example, tendons are usually white because they have limited blood supply. And as I hinted to earlier, a tendon, because of the lack of blood supply, will take longer to heal. Now in yoga, tendon injuries are sometimes very common just due to students' lack of awareness on how to utilize their muscles when practicing yoga. So their tendons take the brunt of some of the stretches in some of the asanas. So when we actually get together for the yoga therapy program, we'll go over specific techniques in helping you to ensure that your students are safely stretching the muscles in the right places, muscle belly versus tendon insertion. And that can really help to reduce the nature, the extent of injury in yoga classes. And then ligaments connect bone to bone. Also lower in blood supply. Ligaments are not like elastic band where if you stretch them to their max capacity, let's say you roll your ankle and these ligaments on the outside get overstretched, it's not like they have this ability to naturally recoil and come back to their original length. And that's why if you have had a severe ankle sprain, you might have sprained your ankle a few more times following, or the doctor may have said you're at higher risk for more ankle sprains just due to the nature of ligaments staying overstretched if they are stretched out. So what do you do in this case, since you can't control the ligaments? If you do stretch out your ligaments, or you're hypermobile like me and have more elastic ligaments, that is where your muscle strength is super important. So again, in our yoga therapy training, we go over a lot of asanas to help safely build strength, which takes a lot of pressure off our tendons and ligaments. And tendons and ligaments injury has 3 different degrees of severity. So there's a grade 1 injury, which is about 25% of a ligament or tendon that's injured. Usually it'll heal in a time span of a few weeks, 6 to 12. There might be some significant swelling and bruising, but usually life goes on once it heals, pretty much back to normal. Some strengthening is usually required following. Grade 2 is a 50% tear of a ligament or a tendon. And this is much more impactful to daily life because it's a longer time span for this injury to heal. And right in the acute phase, so those first 2 weeks of injury, there's usually a lot of swelling, a lot of bruising, a lot of pain. So this is a much more extensive injury that usually requires the help of a health professional, or maybe a yoga therapist, or the combination, to gently bring back mobility, strength, and then proprioception. And grade 3 is the most extensive type of injury, 75% to 100% tear. Now, here's the tricky thing. If there's 100% tear of a ligament or a tendon, or for example a muscle belly, usually surgery is required, but a lot of the times at 100% there's not as much pain as a 50% tear, because the nerves are usually severed as well. So sometimes, like for example, if you know anyone that's had an Achilles complete rupture of the tendon, they'll hear a giant pop, like described like they thought a shotgun went off, or they'll feel a giant pop, and they can actually feel the muscle rolled up into their calf, but they might not experience a lot of pain. They just know that they can't walk, really. My dad actually tore his pec at one time, and didn't feel a lot of pain at all, but felt the muscle rolled up into his chest and had a lot of edema and swelling. And because just of what he described to me over phone, that he couldn't do push-ups anymore, I thought it was a complete tear, and he went to the doctor, and sure enough it was. Okay, so now we're going to talk about some common questions of the structures that we went over. So a very common question that comes up in relation to bones is one about osteopenia and osteoporosis, which is just the weakening of bone, which can be due to lifestyle, sedentary lifestyle. It can be due to diet. There's many different factors. Now they're even saying there's some gene relation as well. And a lot of yoga teachers and healthcare professionals wonder if it's reversible, and it is due to diligence and hard work. So bone strength is built, research is supporting in weight-bearing activities. So activities such as walking, running, strength training where there's weight bearing on the ground, whether it be the legs would be building bone strength in the legs, or the hands, for example, in plank pose would be helping to build bone strength in the arms. So in yoga, bone strength can be built up through yoga postures. Walking is a little bit more efficient in building bone strength just because of the impact, which stimulates some of the bone building growth. However, in our clinic a few years ago, we did have a patient that came in with osteoporosis. So the precursor of the start of decline of bone strength is osteopenia. If that goes on and increases in nature, then it's osteoporosis. So we had a patient come in with osteoporosis and significant scoliosis, actually. And she really wanted to work with her curve and build back her bone strength. So she was very diligent, avoiding such thing as Diet Coke, which can leach the bones. She worked with a nutritionist to really get a broad spectrum of nutrients to help build back bone strength. She walked diligently within her pain tolerance, and she had a yoga asana program that was weight bearing in mind. So they were very specific poses like standing poses, warrior poses to help build bone strength. And after a time span of 6 to 9 months, she went from being osteoporosis to osteopenic. And then she went from being osteopenic to just being in the broad range of being normal. So it can change. It just takes a while. I think that process took her like 12 to 16 months. But it can be reversed. So just know that your students coming in with a sedentary lifestyle, especially if they don't have a good awareness with their diet, they can be at risk for this, especially if they're over the age of 50. Now, if you do have a student, just to keep in the back of your mind, that does have severe osteoporosis or is on the border of osteopenia and osteoporosis, you do want to be careful about deep forward bends and deep twists, because that just puts the vertebrae at risk for fractures. There's actually a certain type of fracture that happens with deep forward bends in the thoracic region called a wedge fracture, only because this part of the bone weakens in nature, and then the pressure from bending forward can cause the fracture. And it's usually pretty painful with patients. It can heal, sometimes surgery is required, but as yoga therapists, you want to be mindful about this and never forcefully assist or aggressively work them into twists. So another question that comes up is in a yoga practice, whether it be a vinyasa flow or hatha style or therapeutic in nature, how does a student, or maybe even in your own personal practice, how do you know if you're stretching a tendon versus a ligament versus where you really want it in the muscle belly? So again, we're going to go over this in more detail in the yoga therapeutics training, but something to start to consider as you practice and as you cue your students is knowing your intention of the pose. So let's take Uttanasana, for example. We know more commonly that it's a very good hamstring stretch. Sometimes, depending on the student's degree of restrictions in the body, it can also be a stretch to some of the muscles of the low back, the glutes, etc., etc. So ideally, though, in Uttanasana or forward fold, the stretch should be felt in the muscle belly of the hamstring. So in your mind, if a student says, well, hey, I have a question, I'm feeling it behind the knee, or maybe up by the sit bone, or sometimes I have students, they feel it the whole length of the leg. In your mind, this is where the importance of knowing where a muscle starts and where it ends is super important. So if you know hamstring muscle, then you know that it starts at the ischial tuberosity, travels down the back of the leg, it's actually a grouping of 3 muscles, and ends on the tibia bone. So it does cross the knee joint, but if you look at the anatomy of a knee joint, there's no meaty muscle bellies right in the back of the knee joint, nor are there any meaty muscle bellies right at the sit bones, right? They're bones, and so what is there are tendons. So if a student is feeling a stretch in the back of the knee or by the sit bone, most likely it is a tendon. So sometimes if you just rationalize it or think logically, okay, what muscle am I attempting to help my students stretch, or yourself, right, if it's your own personal practice, and what is the length of the muscle and where is the muscle belly? So ideally the student should be feeling the stretch here. If it's going along the whole length of the leg, that might be nerves, which we're going to get to in the next section. So analyzing muscle stretching due to location and muscle size is a very helpful way to determine if it's ligaments or tendons, which we want to avoid. Another common question is with the degree of tears, whether it be muscle, ligament, or tendon, if you're a teacher and someone walks into your class, is it your job to determine the grade of tear? First of all, no. Any diagnosis that we go over on this video or in a training, as a yoga teacher, it's never your job to diagnose, right? This is only, we are sharing these diagnoses with you only so when students come into your class with a diagnosis, you don't freeze and you have some tools in your tool belt to know what to do. Or you might decide you need to refer back to the doctor or to another healthcare practitioner like a physical therapist. So typically, with low-grade ankle sprains, for example, a grade 1, or a knee injury, grade 1, students may not even go to the doctor because it's usually not that bad. They'll say something like, oh, I tweaked my knee or I rolled my ankle a couple weeks ago and I'm still kind of healing. Terminology like that may clue you in that, oh, that's a grade 1, they're still working their way through, they definitely need to gain back some strength. Grade 2 and 3, most likely they've definitely seen a doctor, and then the doctor said, oh, okay, you have like 50% of your tendon or ligament or whatever torn. So they're usually already working with some type of healthcare provider. If they're not, now, because yoga is becoming a lot more popular these days for very good reason. So let's say you do have a student that comes into your class with like a lot of swelling, a lot of bruising, and they want to heal and they haven't been to a doctor yet. In this case, you might refer out and have them go see their doctor because imaging might be required. Again, sometimes if the muscle or tendon or ligament is torn so severely, then that joint, whatever the neighboring joint is, will lose its stability. So then if a surgery is required, you just need to know where they are on the scale, so then you know how much to push them as they're healing. So another common question is the meniscus, which is another type of cartilage. So meniscus itself in the knee acts as a shock absorber, and it's a type of fibrocartilage. So again, it's very strong, but it can tear, and it's not very vascular in nature. So some areas of the meniscus do have some good blood supply, and some areas more central, for example, do not. So depending on the degree of tear, how big it is, or where the tear is located, then surgery may or may not be required. Again, not your job to diagnose. As a PT, I can usually figure that out and give a PT diagnosis, so you can refer to PTs, you can refer them back to their doctor. They may need surgery. If they do, those surgeries usually have really, really great success. Usually they'll just clean out that part of the tear, and the student will rehab, which you can help with, and then they go about their life. So another thing that's a common question is, how do you know if an injury is acute or if it's more chronic in nature? So injuries go through kind of a timeline of events. There's an acute phase, there's a repairing, rebuilding phase, and then hopefully then there's the healing and moving forward. If you get stuck in any of the phases and the injury does not heal, then it's labeled chronic. So the acute phase of healing is typically 2 weeks. So the first 2 weeks of an injury, that's the acute phase. And usually rest is best at this point. Very gentle motion. Sometimes people try to come to yoga classes, but a lot of times that actually delays the healing and can be too much. Whereas chronic is, for example, the student that rolled their ankle maybe grade 2, and they came back to yoga too early and kept either rolling their ankle or irritating it, and it delayed the healing, and the healing didn't happen, and the injury went on longer than 3 months or so. That's considered to be more of the chronic phase. And as yoga therapists, there's a lot that you can do, even just beyond the physical asana, which again, we'll get into a lot in the training. Okay, welcome back to the overview of structures, part 2. So now we're going to move on to nerves. Nerves are very, very important. They carry the information from our muscles, our ligaments, different organs, different structures of the body back to the brain, and the brain carries messages back to the organs, muscles, nerves, etc. So part of the nervous system. And the thing about nerves in yoga specifically is that nerves don't like to be stretched. They don't like to be messed with. They're encoded in fascia to help protect them. They're a little vulnerable because they're carrying very important information, and sometimes they're embedded right next to a muscle in these tight little compact areas of the body, and it's not a very neat system, which also leads into the fascia, which is listed below. But when I was in cadaver lab, sometimes it's a big jumbled mess in there. Fascia encasing muscles are stuck to fascia encasing nerves. And so sometimes in yoga, when students are stretching, for example, I hear this for whatever reason very commonly in Parvarita Trikonasana, so twisted triangle. You'll have a student that's rotating possibly a little bit too much through their lumbar spine and pelvis region, and they say, oh, I feel a great stretch all the way down the leg. Or in Uttanasana, they're bending forward. They're like, wow, this stretch is great. I feel it in the back of my leg all the way down into the calf. Now you know, or hopefully will, that hamstring again is going from the sit bone to the back of the knee. The calf is again starting around the knee area and goes down into the ankle. There's no muscle that starts up in the pelvis region and travels all the way down to the foot. Yes, there's fascia that overlays and connects, so maybe what they're feeling is a fascia pull, but the other thing that the student may be feeling is a nerve stretch, which you want to avoid, because nerves, when they're injured, take a long time to heal. If you've ever had an injury where you felt numbness tingling into the hand, or maybe shooting pain down the arm or leg, weakness, all those sorts of things are a nerve injury. And if you've ever had one, I had one in the past, it takes sometimes a year to 2 years to fully heal. Some research supports that nerves heal 1 millimeter a day in the ideal healing environment, meaning the student's not exacerbating their injury by going to yoga and continually stretching in the incorrect way. So think about it, super tiny small increments of healing, which is why as yoga teachers that we really want to prevent and create an awareness about muscle stretching versus nerve stretching and how to tell the difference. So there's actually particular asanas that help to floss a nerve and break up that fascial restrictions that may be connecting the nerve to the muscle, which is part of the reason why it's getting stuck, because it's just getting yanked upon. So know that. So as I hinted, when a nerve is injured, a student may feel numbness and tingling. They may lose their sensation, so they don't feel a certain thing. They may have some weakness. They may have sharp shooting pain or zingers. And usually it's in a specific area. There's these maps called dermatome maps, which help to outline where a student may be feeling their symptoms and which part of the nerve, like at a root level of the spine, might be injured. Now, they're not always precise. We're all human. We're not mapped out exactly the same. It's just a guideline and overview. I find in my own practice that students can vary greatly upon where their nerve is actually being injured and what they feel. But nerves will exit each level of the spine, coming out in between each vertebrae. So they actually will start at the spinal cord in between each of the vertebrae, and there's fascia covering the spinal cord called dura. And then the nerve exits the spinal cord in a foramina, a hole, and becomes the nerve root, which then travels in the neck. The nerves exiting will travel down the arms to the fingers, in the mid-back into the viscera, and abdominal thoracic cavity, and from the low back down into the back of the hips, the front of the thighs, all the way down to the ankles. So the nerve, anywhere along those pathways, whether it be at the nerve root or maybe in the brachial plexus, for example, at the shoulder joint, or if I have some contractor patients that use their forearms a lot, tweaking things so their forearm muscles are really tight, and that can even pinch off the nerve. So the nerve can get injured anywhere along that path, and it's a little bit of detective work to figure that out. It's something I really enjoy, figuring out the puzzle. But in your classes, as you teach, being aware of your cueing to help bring the stretch and the sensation into muscle belly and away from nerve. And then on the healing side of things, creating an environment for the nerve to heal, which means not yanking on it in asanas. So that actually is only just a very little bit of on nerves, but they're very vulnerable, and they don't like to be messed with. Speaking of something else that does not like to be messed with are our discs. Now, if you imagine discs, which are located at each level of the spine. The lumbar discs are super fat and plump because they're containing most of our body weight, but even the neck or the cervical region has some discs as well. I like to compare discs to a balloon. If you imagine a balloon filled with gel. If you squirt on one area of the balloon, the gel will move to the other area, and if you push down on the other area, the gel moves back. So as we move and shift throughout our day, twist and bend, our discs, the fluid in the disc is moving about, and that's good. I had a teacher, he said, motion is lotion. So the more that we move and strengthen and walk and twist and bend, we keep our discs fat and plumpy and pliable, which is what we want. What happens a lot of the time in our society is that, there's actually this research study being done by an archaeologist. It wasn't an official study, it was more of an article. And she compared Westerners, so Americans, and how long they sat and their prevalence of pain compared to different tribes and cultures around the world and how long they sat in their pain. And a lot of the times, Americans, we get a bad rap because we sit for long periods of time. But this archaeologist found that that's not always the case, that there's some tribes and cultures that sit almost as long as Americans. And it's not necessarily how long a person sits, but it's whether they get up and move around, if they're completely static, or more importantly, how do they sit. So in the cultures that she found is that a lot of these non-American cultures, they sit in a way that helps to support the curves of the spine. Now again, there's controversy here that depending on a culture or a tribe that the curves of the spine may vary, but we'll stick to European descent where there's 3 curves of the spine. But a lot of the times when sitting in chairs or couches, people will move into this slump asana position where the pelvis is posteriorly rotated and the spine moves into more of a C shape. And when this happens, and it's done frequently over time and for long periods, then a lot of the pressure and weight is on the front of the disc, which squirts the gel out to the back. And then that's where it kind of gets stuck. And then people get very stiff moving out of that position. But that continuous pressure along with gravity can contribute to some disc issues. So that's why forward bends in yoga with a disc injury a lot of the times should be avoided until someone's healed. However, you want to eventually, the therapy side of things, allow the student to have freedom of movement so they can bend forward or sit in different positions without irritating the discs. But the more they move, the healthier the discs remain. Over time, if that is lacking, then the discs can actually flatten and decrease, and that's known as degenerative disc disease. Hi, welcome back. So we're going to go over questions pertaining to the structures. So this is questions part 2. So pertaining to the nerve, a common question that we receive is, how can I tell if a nerve is being stretched or something else? So I talked about this a little bit by just knowing ideally where the stretch should be felt, like in the belly, just based upon muscle length and location. But another way to tell is also based upon what the student is feeling. Now, only the student is really able to interpret the sensations coming up within their body. And just due to lack of education, really that's usually what it is, they don't realize that all sensations are not muscle. Some do, but most students think every sensation is muscle that they're feeling. So nerves, a lot of the time when they're being stretched, can sometimes have numbness and tingling, or sharp shooting pain, or it's kind of a stretch sometimes that feels really great, but it's different than muscle. It doesn't carry sometimes that shakiness with it, or that ability that makes you want to hold your breath sometimes when you get into the restrictions of a muscle. So what I find with each student, because it's very individualized, especially in one-on-one settings, this is very helpful, is establishing good communication with your student and asking them what they're feeling and have them describe it. And you can even compare it. Have them do a hamstring stretch, for example, on their back, so Supta Baddha Sthasana, with the strap, and isolate the hamstrings so they know what a hamstring stretch feels like. And then maybe compare it to twisted triangle, Parivrtta Trikonasana, and see if there's a difference. Are they feeling the same type of hamstring stretch, or is it varying? Which then leads to the next question: how do I know if it's fascia, muscle, or nerve? And that's tricky because fascia sometimes will refer down to other areas of the body, away from the localized area where it is being stretched or pulled. Ida Rolf compared fascia, which we're going to get to in a little bit, to a sweater. If you imagine a sweater hanging on a hanger, if you pulled one corner of the sweater, then that translates all the way up to the opposite shoulder a lot of the time. So sometimes you can stretch fascia in the neck and feel it down in the mid-back. So it is a little trickier with fascia, but again, if you can isolate a movement and know what you're hitting, then you can transfer that sensation for that student into other areas of the body. Group classes is much harder, but it's a little bit of an art. Communication, again, is very helpful, and just cueing your students, like ideally you want to feel it here, and this is what you should be feeling, not this. Another question is, how can I help nerves to heal? As yoga therapists, there's a lot that you can do to help the nerves heal, but essentially it's giving them the space to heal. So not doing activities or yoga asanas that are going to exacerbate pain. So if there's inflammation in the area, helping the inflammation to calm down, because inflammation takes up space, which can compress on the nerves. So anything you can do to create space for the nerve, whether that's setting them up in a restorative pose, teaching them meditation and breath techniques to calm the nervous system, flush out inflammation. Maybe it's more physical in nature, doing nerve glides to help break up restrictions, to give them space to move with freedom, that sort of thing. So there are very strategic ways to help heal a nerve. How can I tell if a student has a nerve root injury or more distal? Now this is also a little bit tricky, and it's definitely part of a puzzle that sometimes the student doesn't know when they walk in the door. On the other side, sometimes students do know. They have received a diagnosis from a physical therapist or a doctor, so then you have a clue. Oh, they have a C6 nerve root injury, and that's contributing to their pain down the arm. Or they have sciatica, which is really just a garbage term and doesn't really explain a whole lot. We'll get to that in pathologies. But sometimes they'll have a diagnosis. Other ways to determine where the nerve is injured is through movement screens. So the motion is the lotion philosophy. It does apply to students with an injury or degenerative disc disease. It's fine-tuning that motion though. If someone is injured, you want to keep the motion within a pain-free range of motion and then increase the movement as the student heals. And for degenerative disc disease, motion is huge because it'll help to build strength, reduce restrictions, and then give space for the disc to plump and back up, depending upon the severity of injury or the compactness of the disc. It does have room to reverse that degeneration. Another thing I want to mention with discs that's a common question is, are MRIs conclusive? So there is a gray area regarding imaging, MRIs, and disc injury. There's some MRIs that show big disc injuries, and a student may feel no pain. This is documented in a research study. And then there's MRIs that have very little degeneration, or maybe it's just a very small disc bulge, but the student may feel a lot of pain. So what shows up on an MRI is not conclusive to what the student feels. What the student feels is very individualized. So just know it's not a black or white scenario. And the label degenerative disc disease does not mean that they will be in pain forever. Or if they have a disc bulge on an MRI, it doesn't mean that they're going to have a lifetime of pain. It can heal and reverse. And it might not mean that the disc is completely reabsorbed back into the body, but it can decrease in size. The more important thing is if they're feeling pain or not. And then the last question, it's more of a broader question, is what do I do when I receive a referral from a healthcare professional? And you know, Ilya and I work together, and sometimes we share students and clients back and forth. So this is why all this terminology, diagnoses, all this specific information that's not directly related to yoga, but it's why we're going over it, so you can more efficiently communicate with other healthcare providers and refer back and forth. If someone catches on that you know the lingo, then they're gonna already immediately know in their head that you know what you're talking about, and so they're gonna have a higher propensity to trust you and then refer you people. Plus, terminology and diagnoses is kind of leveling out the slate, because you know, with different countries, different languages, different philosophies and ways to view things, a diagnosis or terminology just keeps the playing field the same. So if someone says, oh, they're flexion-based sensitive, then I already know in my head when they flex, they're going to have pain. It can transfer and cross over easily. So there's lack of so that way there isn't any miscommunication. So that's the end of the questions for this section.